This professional development activity has been jointly provided collaboratively with the Oklahoma Medical Reserve Corps and the OU College of Nursing. For those wishing to obtain CE credit through the Oklahoma Department of Mental Health and Substance Abuse Services, you need to click on that link and use that promo code. If you are unable to write all that down real quick, Teresa will be able to email you that slide upon request, I'm sure.
So that information is also in the registration through the Oklahoma MRC website. So if you go back to that information, that should be there. For any nurses, please just email me directly with the subject line Stress First Aid CE for Nurses, and then I will get you the information that you need to obtain CE credit.
This is the webinar link, which apparently you found because you're here. And if there's the digital audio links in the listen by phone mode. So attendees should remain on mute, and we will conduct a Q&A at the end. There is an open chat at the bottom of your screen. Just type in your question as the program goes along. Teresa will gather those questions and ask them at the end. The training dates are today, next Friday, and the Friday after that from 10 to 12. This is a three-part presentation, 2 hours each of CE will be obtained through each session with a total of 6 hours. I am the presenter, Dr. John Call, with the Oklahoma Medical Reserve Corps Stress Response Team. Most of you probably have attended other presentations like PFA or Skills for Psychological Recovery that I presented over the years. But for those of you who don't know me, let me just give a brief overview of my professional background. I am a forensic psychologist, an attorney, and also trained as an emergency medical technician. I have been a member of the Oklahoma Medical Reserve Corps since 2005. The purpose of this workshop is to introduce you to a strategy designed to provide assistance, enhancing emotional and behavioral health to peers, children, adults, and families, both during and in the aftermath of disaster. Stress First Aid has been developed by the National Center for PTSD by many of the same professionals who develop psychological first aid and skills for psychological recovery. This workshop is being presented by SRT Inc. and Oklahoma Nonprofit Corporation, as well as the College of Nursing and the Oklahoma Medical Reserve Corps. Let's go back about 25 years. In April of 1995, I was driving down I-35 to my office at about 9 o'clock in the morning, driving by Frontier City, for those of you who have been on I-35 in Oklahoma City. I saw a mushroom cloud develop over the city. And that was, I found out a little bit later, was the Burra building going up in its smoke through the explosion, the bombing. That month, the governor had appointed me as a member of the board of directors of the Oklahoma State Department of Mental Health and Substance Abuse Services. And that agency had been given the lead to develop what turned out to be America's first community mental health program post-terrorist event. Now, as a forensic psychologist, I've spent my career in part doing criminal behavior profiling. And I used the same concepts as I began to help design and develop Project Heartland. And I learned that there are different profiles to different types of disasters. We are in the midst of a pandemic. Let's take a moment and profile this current disaster. It's a prolonged diffuse disaster, quite different than, let's say, a tornado, which is an acute localized disaster, or a bombing. A pandemic, as opposed to a tornado or a bombing or a fire, has no clear-cut geographical boundaries. And in fact, it's worldwide. And there's no chronological boundaries. We don't know when it's going to end. A pandemic impacts society and individuals in multiple foreseeable and unforeseeable ways. It precipitates further disasters and crises, both during and following its existence. A pandemic negatively impacts everyone in one way or another, notwithstanding whether or not they become ill. The 2020 COVID-19 pandemic is impacting us economically, socially, physically, emotionally. The next slide I thought was quite interesting, and I obtained it in October of last year. It compares our current pandemic to other deadly events. Now, you'll see that on October the 6th, we had 210,000 plus dead from the current pandemic. Now it's 430,000, more than double since October. Take a look and compare. We now have more deaths from the pandemic than World War II, than American servicemen in World War II, or World War I, Vietnam War, and Korean War put together. Currently, only the Civil War and the 1918-19 flu pandemic have more deaths. The pandemic has unique impact in the precipitating both individual and societal maladaptive reactions. You know, it's to be expected that a portion of those impacted by such a prolonged diffuse disaster as we are experiencing, both citizens and governmental leaders, will inappropriately use denial, magical thinking, and displaced aggression in a maladaptive attempt to deal with the heightened emotional distress that a pandemic precipitates. As one of my professors used to say, denial is not just a river in Egypt. As we see this reaction nationwide with a debate regarding the use of face masks. I saw in the news today, even instances where people attacked others aggressively because they were asked to wear a face mask in a grocery store. And recently I read of examples where people attacked others who were wearing masks. Why should you care if I wear a mask? Obviously, there is displaced aggression. The question we Medical Reserve Corps volunteers face is how we can individually as well as institutionally more positively impact both our volunteers as well as those citizens we serve during this heightened period of stress. my opinion, the prolonged diffuse disaster we're experiencing will only get worse. We have an effective vaccine presently, but it has to be administered to the vast majority of 329 million people. That is a phenomenal job. As a prudent disaster behavioral health specialist, I believe we should prepare ourselves, our families, our communities for the long run. And what do I mean by long run? In my opinion, a long run is more than a year. Welcome to Stress First Aid Training. Stress First Aid is a set of supportive actions designed to help you with self-care, to help you with peer support, to mitigate negative impacts of stress. What is Stress First Aid? It's a framework to improve recovery from stress reactions, both in oneself and in peers. It's based on research supporting the value of key elements that are related to recovery from different types of ongoing adversity. The framework aims to support and validate good friendship, mentorship, leadership actions. SFA addresses stress reactions before they create larger problems that can derail health, relationships, or a career. Flexibility and tiny steps are emphasized in SFA. SFA should always be tailored in a flexible way to fit your personality and style, as well as your capacity to help others in any given moment. It should look different for each person who implements it, and within each context it's implemented within. Mentoring and problem solving are highlighted. Your role may be to provide immediate support and possible assistance, either verbally or through your actions, to someone reacting to an overwhelming stress in a highly stressful moment. Or you may need to help a peer problem solve and manage tasks that seem overwhelming to them when they've been under significant stress for an extended period of time. Now, Stress First Aid is not meant to address all ranges of issues. It's a first aid model, and it's not designed to deal with lifelong problems or serious mental health issues or complex problems that require more intensive interventions. But bridging to a higher care is important and is recommended when indicated. Always think in terms of referring a person to an employee assistance program or a mental health provider or other professional if they're having difficulty adjusting and are experiencing disabling or persistent stress reactions. Being a bridge to that type of care may be your most helpful Stress First Aid action. We use the stress continuum model, and this was developed as a visual tool for assessing an individual's stress experiences, and it forms the foundation for Stress First Aid. Stress responses lie along a continuum of severity and type, from transient and mild to chronic and debilitating. The continuum has 4 zones: ready, green; reacting, yellow; injured, orange; and ill, red. It is important to note that 100% of people react when faced with significantly stressful experiences. However, the way in which they respond will depend on many factors, including how prepared they are for the stressor and how they interpret it. A person's reactions can range from relatively rapidly from moving to green to yellow or to orange or red and back again. This is interesting. See, stress first aid was adapted from the Navy Marine Corps Combat Operational Stress First Aid. It was developed for combat soldiers and Marines. The stress continuum model was developed as a visual tool for assessing individual stress responses and forms the foundation for SFA. It was designed to reduce stigma by showing that people can go in and out of ranges of stress reactions frequently based upon a variety of factors. Now, this model acknowledges that within this range of reactions to stress, a person can go from being in optimal functioning, feeling good, mentally and physically fit, mission focused, calm, into what is called the yellow zone. In the yellow zone, a person can feel more irritable, anxious, or down, have a loss of motivation, loss of focus, have trouble sleeping, muscle tension, or other physical changes. But these are transient reactions. Now, movement into the orange zone is usually caused by an accumulation of different types of stressors or a pretty severe stressor event. In the orange zone, you start to see more severe and persistent distress or impairment. The person doesn't feel like themselves, or they've lost control of their stress reactions. They might feel strong panic or depression, rage, guilt, or blame. In this zone, it starts to feel like the stress leaves a scar, and the person is at high risk for having trouble functioning and strong or persistent stress. The red zone is reserved for diagnoses like PTSD, depression, anxiety, or substance abuse. What signifies a person being in the red zone is that their symptoms are very persistent or worsen over time. The person experiences severe distress or has significant difficulty functioning at work or in their home life. Now, the stress first aid model was designed to help people move themselves or their peers from the red and orange zone back to the yellow or green zone. The ethos in high stress work cultures has been that after a difficult event, one should be able to tough it out. And this is still the case in many settings like law enforcement, fire department, military, where the stigma associated with reacting to stress or stress injury behaviors is still very real, and people will try to conceal their stress reactions from supervisors to avoid medical or psychological intervention. However, it's usually not possible to keep these behaviors hidden for long from family members, peers, friends. When a peer recognizes that someone is in trouble, or an individual recognizes that they are in trouble, it is important to try to assist in some way. Getting this individual connected with the next level of help as soon as possible may help prevent their reaction from progressing into the red zone. Once an individual has moved into the red zone, the goal is to help get them into treatment as soon as possible. This is the stress first aid model. There are 7 SFA core actions. Check, coordinate, cover, calm, connect, competence, and confidence. Each core action has 3 parts. Contact explains how to establish a partnership with the person in crisis. Question explains what data to collect, how to collect it, and how to manage the process. Act describes how to deliver information in a way that makes it likely that the person will accept and comply. One of the reasons why I like SFA is that it is very easy to understand, very easy to compartmentalize. 7 core actions, and each of the 7 core actions can be understood into 3 components. Stress first aid is based on research literature that says people tend to do better in ongoing stressful circumstances when they have one or more of 5 essential elements to counteract that adversity. And those elements are being able to move towards a greater feeling of safety, being able to calm themselves, feeling connected to others, feeling that they will be able to get through what they're having to deal with, and having a sense of optimism, faith, or hope. There are some basic, essential SFA skills, and these skills are relevant to all of the core actions. Paying more attention to signs of stress reaction in oneself and one's peers. Recognizing when stress reactions are in the orange or red zone of the stress continuum. The recognizing. Then acting early in response to your own or a peer's stress. If you see something, do something. We've all heard that before. And it applies to behavioral health. If you see something, do something, either for yourself or for your peer. Or you may need to say something to the person themselves or to somebody they trust. And lastly, knowing at least 2 resources that you would either access yourself or offer to a peer in distress. It is helpful to know a range of both organizational and community resources. Remember that SFA is both a peer support and a self-care model that can be used to support peers, family members, friends, citizens at a pod, but also to increase your own self-awareness and improve your own early response to stressors in your life. So how can you use SFA? The stress first aid framework of possible actions was designed to be very flexible. So here's an example of how SFA can be used in peer support. Ideally, what you would do ahead of any SFA action is to pay attention and be aware of what's happening either in a highly stressful moment or in a person's ongoing circumstances. Paying attention in this way allows you to see changes in the way that the person is reacting or functioning that would indicate that they are stressed. Then you would either act to mitigate the stressful circumstance in the moment or approach the person and together decide what they most need at that time. So, for example, you have observed the individual, that you've interacted with them. Are they dealing with anxiety? Are they dealing with isolation? What is the issue? Each one of these stress reactions could be handled differently. depending upon your personality, what's going on in the moment or in the person's life, what they're most likely to respond to or be able to tolerate, or what makes the most sense. Let's say, for example, anxiety. Anxiety, a core action that would work with anxiety is the calming core action. Likewise, the cover core action is applicable and might be preferred by the individual or yourself. Or competence. See, the model allows you to be both practical and creative depending upon many factors, and should look different with every exchange that you have with the peer. It's not a one-size-fits-all model. That can make it challenging to use for some people because there is no one prescribed set of actions. But the hope is that it gives people permission to use the model in a way that makes the most sense to their own role and personality, and the roles and personality of their peer or family member or friend, as well as the specific situation at hand. SFA is also a framework that validates what you are already doing to help peers feel safer, calmer, more connected, competent, and confident. So what's today's focus? Today's focus is upon the first three core actions: check, coordinate, and cover. The goals of check are to identify the current levels of stress. One looks for indicators of ability to function in the role. Determine the need for one of the other SFA core actions or other physical, emotional, social, or spiritual support, or for others who might need to know of the situation, or others who might be able to help. General check actions: observe, look and listen, record. What stressors are you observing? What changes in functioning are you noting? How does the individual respond to interventions if they have been implemented? Examine. Examine by having one-on-one interactions with the individual, the peer, the friend, the family. Collateral information from other connected individuals, other peers, other friends. Decide what stress zone are you noting you would place the individual? Are they still in yellow or have they moved to orange? Are they in the red zone, the danger zone? Because that's going to indicate certain specific behaviors on your part. Specific check indicators, for example, looking for stress indicators, the level of distress. You're going to look for behaviors. Are they agitated? This is going to suggest information which you can analyze to get at that level. Are there outbursts of emotionality? Is there depression? Listen for verbal cues which supplement the observations that you're noting. Again, look in the stress indicators. What current stressors are you observing in that individual's life? If you're looking at yourself in your own life, look for, is there a loss? Do you note harmful events happening? Are you observing or look for various yellow zone stress reactions? As a part of your observation, listen for verbal cues that will give you more information about what current stressors are impacting the individual. You see, what's happening to all of us is that compared to, a year and a half ago, we are all under increased stress. Even if we spend all of our time in our home, that it's because of being afraid of going out and catching COVID-19. That in itself is stressful. And then as medical and healthcare professionals, working in the pod is stressful. Heck, going to a pod is stressful. Trying to get an appointment is stressful. More stress indicators. Are there changes in functioning? Look for drops in performance, forgetfulness, loss of control of emotions. Listen for various verbalizations, again, that support what you observe. So the check function is looking for and listening for behaviors and verbalizations, which gives you information about the stress the individual is experiencing. Now, another tool is the Oscar communication technique. The Oscar technique can be used to survey an individual for orange zone indicators and to gather information to answer the following questions. Which stress zone is the individual currently in and why? Would he or she benefit from any of the secondary SFA actions to restore calm, create social connections, build personal competence, or enhance self-confidence? Is a referral for further medical or behavioral health evaluation warrant? Oscar, observe. State the observations to the individual. Clarify your role, tell why you're concerned. Ask why, seek clarification, get their perceptions of their behavior. Respond. Check collateral sources of information and check. During the check process, it may also be helpful or necessary to discuss the situation with coworkers or family members. And using the Oscar technique, again, look and listen for clues about the three orange zone indicators: current and recent stressors, indications of internal distress, evidence of loss of previous functional capacity or changes in functioning. Information received from these collateral sources will either support or conflict with the information that was gathered from the individual. Either way, it will probably be useful in the process of making accurate assessments and sound intervention decisions. Remember to recheck. Rechecking, it's important to remember that is never a one-time effort. Check is never a one-time effort. Even if an individual seems to be coping well, the initial indicator that prompted check might increase the risk of developing orange zone stress in the future. In fact, any SFA action should be followed up over time by recheck. A check action, which I have selected as a tool from Skills for Psychological Recovery, is called information gathering. A check action such as information gathering, which I'm going to discuss in a minute, is a tool which you would utilize with an individual that you have a more established relationship. Let's say somebody at work that you have been working with for a period of time, or somebody at a fellow pod worker or MRC volunteer who you know and have been working with, a family member or a peer. This type of the details of this tool would not necessarily be appropriate with a citizen who you've just met and is walking through a pod and is stopping at your station. You would not use this particular tool in that kind of very brief interlude. But let's go ahead and take a look at it because it is sometimes applicable. Again, remember, the goals of information gathering are to determine if there's a need for urgent referral or referral for available ancillary services. You want to understand the person's most pressing current needs and concerns, and then you want to prioritize and plan your intervention strategy. So the steps. You want to identify current needs and concerns. Step one. You want to summarize and prioritize the areas to address. Step two. You want to make an action plan. So here's for example, sample language that you might work with. You might say to somebody who you have a bit of a relationship with. To be able to meet your most pressing needs and concerns, let me ask you a couple of questions that cover some important problem areas where we could work together to address. I'm going to ask you on a scale of 1 to 5 how big each of these problems is for you right now. First, though, is there something you are really concerned about right now? If there is, let's talk about that first. Note that last sentence. Let the individual, give them an invitation to direct you as to what they think their most biggest concern is. There's actually a checklist, and here's an example of it. This is taken from one of the appendices in the Skills for Psychological Recovery. It's a screening form. And note that there are problem areas: physical health, emotional difficulties, safety, basic necessities, substance use, role functioning, interpersonal life, other concerns. You can utilize this tool actually as a guide in this more detailed information gathering. And you can ask them how much of a problem each of these areas is. Even if you don't have this particular form with you, you can memorize these potential problem areas. And again, let me just state this, obviously, this particular in-depth checking tool is most appropriate with somebody who you have a bit of a relationship with, as opposed to a citizen walking through a pod. Provider alert. Remember that the primary goal of SFA is to use the time available to help the person address their current problems. SFA is a problem and solution focused intervention. It is therefore important, especially as you may have only one meeting with the person, to use that time effectively. So, step 2, after you've gathered the information, you should be able to identify the urgent problems, identify less urgent problems that would still need an appropriate referral. You should be able to prioritize those problems. You should be able to select an intervention strategy from the other SFA core actions to address the identified problem and discuss the number of meetings that might be needed. Generally speaking, in a situation where you might be helping an individual, mentoring them over a period of time, the number of meetings would be probably no more than 2, 3, maximum 4. Otherwise, if it's something more intense, a referral would be appropriate. Summarize and prioritize concerns. For example, they give us some sample language here. You know, we talked about a number of things. Let me see if I can summarize what you've said. It sounds like your major concerns right now are whatever they are. Have I got that right? Remember to give the individual adequate time to ask questions and share their views. So now we have to prioritize. Remember that deciding what problems to focus on, it's useful to consider the problem is identified by the person as a major problem. The problem is causing serious distress. The problem needs to be addressed sooner than the others. The problem is worsening over time. That perhaps addressing that particular problem will reduce others. And remember this, the person prefers help with this problem first. Make an action plan. You should explain that many of the problem areas should be addressed using a different SFA strategy. Work with the individual to select which SFA strategy to use. The first step in accomplishing this is to briefly review the relevant intervention options for that particular problem and to find out about the person's preference. You remember this slide? This is what we're talking about in terms of, after we've identified the problem, reviewing with the individual the different core actions from SFA that might be applicable to that particular problem. For example, isolation. Well, the connect and or the confidence core action are 2 which are likely to be applicable. Let's go back to that slide. You see how that is designed to be flexible? I would recommend that you might make a note of this slide and just put it into your mind. Which of these areas and core actions are most relevant? So here's some language, that you can use at this point when making an action plan. We have identified a problem area that we can work on together with the rest of our time today, and we've agreed that the problem we'll work on together is whatever it is. There are several ways that this problem could be addressed. For example, for this kind of problem, we can work on and explain the relevant core action. So have you had experience with any of these? Which one do you think you would be more comfortable with? Which one do you prefer that we use first? Challenges to information gathering. Building rapport through active questioning and planning versus support listening. Because what happens is that in information gathering and in checking, after observation and listening, we need to question. This is different than traditional counseling, non-directive, in particular, non-directive Rogerian counseling, which is supportive listening, which takes a lot of time. We don't have a lot of time. Another challenge to information gathering is identifying needs and concerns efficiently, but in enough detail to prioritize and make an action plan. Not getting bogged down in too much detail. Determining priorities, especially when there are many pressing concerns. Well, that takes care of core action number 1. Check. It's kind of like being a detective. You observe, you listen, you question. But you also try to invite the individual to do the same. To step outside of themselves, to note their own behavior and develop motivation to do something about it. Let's take a look at core action 2, coordinate. The goals of coordinate are to inform those who need to know and to obtain other sources of needed help or care. This figure shows the major components of the coordinate function. There are 3 actions that may follow depending upon the information gathered during check. Collaborate. Collaborate means forming a partnership with the affected individual to expand resources and options that may have been depleted by the stress. This action is about getting the person to the next level of support, which could be a mentor, a trusted coworker, a trained peer support member, employee assistance resource, a supervisor, a trusted supervisor, who is brought in to collaborate. That individual is dependent upon what the situation is and what the existing relationship with the individual is. You wouldn't want to bring in a individual like a boss or a subordinate who the peer did not trust. But it could be a peer counselor, a fellow crew member, somebody, a trusted family member, or yourself. Next, inform. Inform implies actively engaging key individuals who have a need to know, have the ability to help within the organization, or able to offer emotional support. This action is most effective when it's done in collaboration with the affected individual. Refer. Refer is to bridge the individual to a higher level of care when indicated. It is critical that SFA providers understand boundaries and the limits of their capabilities. When department members are suffering stress injuries beyond the scope of trained peers, and other SFA providers, they need to be connected with the appropriate organizational support or appropriate community support. Core action 3, cover. To provide cover means to ensure ongoing safety. The components of cover for use with peers involve standing by. Standing by a peer and remaining available and ready to assist as needed. Watching and listening for ways you might intervene if needed, or holding the person's attention if they are overwhelmed or panicking. Making the person safe. Making them safe in a way, in any way you can, including, if necessary, being an authoritative presence by warning the person, by protecting the person physically or psychologically, or by assisting the person. When necessary, cover may also involve making others safe from the person if they are not functioning well because of stress reactions. You could do this by protecting them physically or warning them about possible dangers that might result via the stressed person's action. Encouraging a perception of safety occurs in the long term for both workers and their families via a caring presence, listening to feedback, and communicating about safety and greater commitment to organizational safety and order. This can be physically via maintenance of equipment and attention to worker fatigue and burnout, and mentally, emotionally by reducing chaos and rumors. Keeping in mind that stress first aid occurs only as needed and should be mapped into the context and the personalities of those involved. Here are a few examples of how to provide cover or safety, depending upon the situation. You could, for example, ask about what's making the person feel unsafe. Reduce anything that makes them feel unsafe. Reassure them that they're safe in the moment. Educate them about how to be or feel safer when they're having flashbacks or trouble sleeping. In the context of a very stressful moment, focus on what to do rather than what not to do. Provide an authoritative and accurate voice to help limit the level of perceived threat. You can also support their psychological sense of safety through these 3 SFA components. And these are specifically designed for use in a pod. The cover component, contact in a pod. Don't assume that people know your role. Introduce yourself. Ask for the person's name and refer to them by name thereafter. Be respectful. A very simple cover component, contact. A cover component, question in the pod. Ask if they have any questions about what's going to happen. Ask if they have any special needs. Ask, are you okay? Do you need help? Depending upon their answers, ask if they would like to speak to a member of the stress response team or behavioral health specialist that happens to be volunteering. Cover component, act in a pod. if warranted, ensure that affected individuals, citizen or peer, is moved to a safe location. Direct people's behavior by telling them what to do rather than what not to do. For example, instead of saying, get out of the way, try, I need you to move over here so you don't get hurt. Train pod peers on situational awareness and decision-making under stress. Seek advice from the stress response team member or other behavioral health professional volunteer about troubling issues that arise. A cover action. This is probably one of the most significant cover actions that you might have to do. Suicide intervention. This section is called the OODA Loop and suicide intervention. I bet you not too many of you have heard of the OODA Loop, unless you, like me, were in the United States Air Force. You see, the OODA Loop is the cycle observe, orient, decide, act, and developed by Colonel John Boyd of the United States Air Force, originally applied to combat operations. But the OODA Loop has become an important concept in numerous decision-making processes, including suicide intervention. If you think about it, the OODA Loop is not that complex. It has the observation aspect and the decision aspect based upon what you observe, and then the implementation or the acting aspect. Orientation is that link between observing and deciding. Observe the target person. Look for clues of suicidality. Orient the person to the problem. Ask about their thoughts and plans. Based upon what you observe and about what you found out through the orientation, decide, what are you going to do? Once you decide, then act. Assist the person if needed to seek the help they need to stay alive. Let's take a look at some of these in a little bit more detail. The OODA Observe. Here are some direct verbal cues. I've decided to kill myself. Well, that's darn direct. And there are some others here too, which are pretty direct. Then there's the indirect verbal cue, which frankly is what I've run into more often as opposed to the direct verbal cue. I just want out. I'm tired of life. I just can't go on. I can't stand this pandemic anymore. I can't stand being at home all the time. Possible indirect verbal cues. Besides verbal cues, there are behavioral cues. For example, a previous suicide attempt is a behavioral cue. One of the basic rules of psychology is the best predictor of future behavior is past behavior. If a person has previously attempted suicide, one needs to be aware of that, since there is a heightened probability that they might want to utilize that maladaptive response once more. Again, being aware of some of these behavioral cues would take a bit of a relationship. This type of interaction, observation occurs with an individual that is a peer, family member, friend, somebody you supervise, as opposed to maybe a citizen who's just walking through a pond. Besides behavioral cues, there's social cues. Loss of a major relationship, a recent divorce, a diagnosis of a serious or terminal illness, anticipated loss of financial security, a fear of becoming a burden to others. This third one, anticipated loss of financial security. I don't know how many of you have remember seeing just in the last few days about the young man who committed suicide after he thought that he had lost $750,000 investing with Robinhood in the GameStop fiasco. Now, that's observable. In Orient, there are 3 A's. You analyze what you have observed. And you decide if you need to approach the individual. And if you do decide you need to approach the individual, you have to ask them. So ultimately, you're going to ask the question in the Orient part of the OODA Loop. The question, you say? Yes. You're going to ask the question about suicide. If in doubt, here's some tips. If in doubt, don't wait. Ask the question. If the person is reluctant, be persistent. Talk in a private setting. Allow the person to talk freely. Give yourself plenty of time. Have your resources handy. Have phone numbers, have referral sources, everything lined up ahead of time before you ask the question. Now, there is a less direct approach. But here are some examples. Have you been unhappy lately? Do you wish you could go to sleep and never wake up? Have you been so unhappy lately that you've been thinking about hurting yourself? There's nothing wrong with using the less direct approach, but as a beginner only. When I say a beginner, as the first lead-in question to what? To the direct approach. You need to use ultimately the direct approach. Are you thinking about suicide? Are you thinking about killing yourself? In the past week, including today, have you wanted to kill yourself? Now those are tough questions to ask somebody. So if you can ask that question, you need to find someone who can. You have to be honest with yourself. How not to ask the question. Well, here are some examples of how not to ask the question. You're not thinking of suicide, are you? You're not thinking of doing something stupid, are you? Well, I know you can't be suicidal, right? Obviously, what's wrong with these questions? It gives the individual a chance to deny. And remember, denial is just not a river in Egypt. So now we're at the decide. And there's 3 D's to decide: discuss, deduce, determine. You discuss with the individual. Based upon that discussion, you deduce what is the best route to go, the best action to implement, and you then determine that is what you're going to do. So in the decide component of the OODA Loop, how to keep someone alive, you listen to the problem and you give them your full attention. Remember, suicide is not the problem, only the solution to a perceived unsolvable problem. Do not rush to judgment. Offer hope in any form. You want to get to a yes. Express that you want the person to live. Show empathy. Make it clear you're on their side. Get others involved if necessary. Never promise to keep secrets. Once the person has acknowledged that they want or need to live, ask, will you go with me to get help? Will you let me help you get help? Or do you feel safe with me while we find you help? This is a part of selling the action to the individual, helping them to decide to act. So the last part of the OODA Loop is acting. It's not over when they decide to get help. You have to do something more. An agreement not to die by suicide is not the end of the conversation. Don't judge or try to give advice. Merely offer hope, then refer to an appropriate support. Let your actions speak for you even when the crisis is over. Try to follow up and remain supportive. So, what are your options? Well, you can use the National Suicide Prevention Lifeline if the individual is not in immediate danger and has no means to harm himself. If the person has identified strong protective factors that will keep them alive, and if you have a means of following up with the person and assuring that they keep appointments for support. But if those conditions aren't met, you will need to use a mobile crisis. If the individual has indicated that they have strong and immediate desire to die by suicide, they've got a plan or a vision of how they wish to die, and they're reluctant to agree to seek support, consider a walk-in crisis center or an emergency room situation. The fact of the matter is, in certain circumstances, you need to call 911. The person is in an altered state of mind due to mental illness or substance use. The person has already initiated the harm to themselves. They have a weapon or a dangerous tool which they can utilize to kill themselves. The person has expressed a desire and has the means to harm other people or to commit dangerous crime. Assure the person that you are calling 911 for their well-being and not to have them arrested. Okay. Teresa, I'm getting ready to go into a discussion time, and I'm hoping that we will have a significant number of questions and topics. Ladies and gentlemen, it's 11:15. I'm hoping that we'll be able to go for at least another half hour with questions and discussion. And we will be quitting a little early today because I have an appointment. But we will expand other sessions to cover the necessary CEU time. So, time for you to take charge. This individual here, as you can see, has just attended one of my presentations. And she's decided and determined that she's going to take the information, join the Medical Reserve Corps, and take charge. Remember the purpose of the Medical Reserve Corps. MRC units engage their volunteers to strengthen public health, improve emergency response capabilities, and build community resilience. We prepare for and respond to natural disasters, and that's what we're doing right now. But the difference is that this natural disaster is going to go on for years. And there's not going to just be one pod for 1 month. There's going to be 100+ pods for a year. A lot of stress there, ladies and gentlemen. A lot of stress in ourselves, our family, our peers, and the citizens we serve. Look what's been going on nationally. Look at the different conspiracy theories, the disruption politically. A significant part, a significant part, in my opinion, the pandemic is having a part to play in this. Your next steps, if you're not already a volunteer, join the Medical Reserve Corps and SRT. Feel free to contact me by phone or email. If you have questions, recommendations, issues regarding disaster, crisis, behavioral health, and I wish to end the formal presentation at this point. Thank you very much. We'll be going on to next week to the next 2 SFA actions. But I wish to have a free-flowing discussion. And I will turn it over to Teresa.
Okay, we do have a few questions. Excuse me. To Douglas, yes, we are looking at, I'm sorry, to Kim. Yes, we are looking at having these slides available afterwards. So you definitely will have access to them. And I will email everyone who registered through the Oklahoma MRC the location of where these will be. So again, if you did not register through the OK MRC website, please do so. You just go to the calendar and hit, basically fill in the information to register for the course, and then you will be registered, and then I can send you the information about CE, where to find the slides, all of that. Okay, we did have a question from Douglas. And Douglas, this was a little earlier on, so if you could go ahead and unmute yourself and just let us know. He had a question about, he was looking for some specific examples, and I don't recall which part of the presentation that was in reference to.
Oh, I was just talking about a specific example, like if you notice a co-volunteering stress, and you know, I think as he went through, he pretty well answered a lot of that. But you know, it's nice to just have a couple of role playing. You know, like you say, you are caregiver or the co-volunteer and you approach someone, just go through a few steps of how you would do it. Like you're there and that person. I kind of get what he's saying from the overall presentation, but it's nice to have a couple of role playing models. Just really short, you know. Like
that's a good idea. What you're asking, if I'm correct, is like you would like to see maybe a couple of role-playing examples of how you might use SFA, particularly in working as a volunteer in a pod with a co-volunteer, for example.
Yeah,
or,
co-volunteer
or a citizen.
Citizen that is not mask compliant or under stress. You know, just a few role examples. You don't even have to have role players. Just you say, I would, if I see one, here's how I would. He says this, and I would do this. You know, just a few short examples like that. I think that's great.
That's
it gets kind of textbook, you know, most of the stuff. So humanize it just a little bit.
I think that's a very, very good idea. And right off the top of my head, one of the things, and I would invite anybody who is attending right now, if they have some examples, to share examples. And Douglas, I'm going to think about this as well and include more next Friday and Friday after that. But I'm looking at you, Neil. I know that you might have an example or two, but one example I'm going to give right now is, you know, one of the problems is one of the things I've run into just recently is where a volunteers had, I'm going to call it, had their feelings hurt. They while providing services at a pod, and the person who they were upset with, or who they felt was hurting, you know, who kind of in a sense, attacked them verbally, kind of, was a staff member supervisor. You know, being a volunteer it has its issues, both for the volunteer and for the organization. So one of the things I said, I walked through with her, with this individual, is like, well, gosh, how, you know, first off is, tell me more about what happened, and then tell me about what you felt. What did you say? And getting at, you know, what had occurred, what they felt about it, what was her feeling of anger and anxiety and frustration, and then finding out, well, then problem solving, and then see this has to do with competence, the core action competence. You know, what could you have done? How would you want to problem solve that if that happens again? So and then you know, going through the kind of the calming core action, which is the calming core action we're going to talk about next week, and the competence core action we're going to be talking about 2 weeks from now, would be two actions that could be used with this particular woman who had her feelings hurt. And then the confidence action by saying, you know, what you were verbally abused inappropriately, frankly, and what you did was what your supervisor did was not good supervision. So what do you think was going on with her? Maybe that supervisor was under a lot of stress. Maybe they're having their problem and they're taking it out on you. Okay. So then giving them confidence about their role, and then maybe role playing and giving them some particular problem solving techniques on how to actually invite a supervisor to interact in a more appropriate way with you in the stress of the pod. So that is one example in general term of something I've actually had to deal with. Anybody else?
Yeah, I'll chip in. One of the things that I've noticed, and it goes along with what you were saying, is that stress is pervasive in this COVID situation, and therefore you'll be working, with a peer, and the peer may say, "I feel burned out." Now, but the thing is, everyone in the team may be burned out, and so it doesn't. The question then becomes, can I ascertain, is the person coping with it? Is it something that needs to be addressed right now? And I think earlier on we talked about, you don't just do these things once, you go and check back, exactly what step that is. So maybe at that point it's just try to ascertain, is the person just acknowledging the situation, in which case it's healthy and they're functioning all right. But I do want to check back with them afterwards and have a little more in-depth discussion and elaboration. Or maybe it's hey, wait a minute, dead stop, I'm burned out. I tend to see that more in this COVID situation than in other previous things.
Yes.
Another example I have seen of stresses amongst the volunteers is that since with the just-in-time training, that sometimes you don't really feel like you're fully trained for the role you're stepping into, and then that a lot of uncertainties amongst especially new volunteers. And so, in thinking about what you've shared today, Dr. Call, I think that step of that cover step of kind of just, what can I do to help? Let me listen to you. I'm kind of standing by you as you're trying to figure out your role. And then, trying to remember that with our chain of command, we've got these unit coordinators or a staging liaison that we can go to say, hey, I'm still not sure what it is that my role is supposed to be, and help me feel more competent in being able to accomplish that. I think we can, as volunteers, we can kind of help encourage each other in that way at times.
Calming, I think I heard that. And then competence, that's another core action. And feeling, if you feel competent, then you're less anxious. Those are other examples. Somebody said it's helpful just to ask, what can I do for you today? I saw that from Janet McClanahan.
I did have another question from Dennis Neal. He says, what if the individual is having a panic attack, which makes it difficult to determine what other issues the individual is dealing with? This happened in one of our pods and made it difficult to determine if the person was having a reaction to the vaccine.
Okay, that's a very good question, very realistic. If an individual was demonstrating a panic attack, and you are not a healthcare or behavioral healthcare professional, one of the first things you would want to do would be to seek out that healthcare or behavioral healthcare professional who has been designated to deal with this issue. I assume that this panic attack was when they were waiting after the inoculation. I'm going to go with that assumption. There should be somebody in my mind, and I don't know how each pod is working, but there should be somebody designated to deal with both behavioral issues as well as health issues during that waiting period. Now, so that's where the bridging comes in. If you're not a healthcare or behavioral healthcare professional yourself, and you're the first one on the spot, you're going to be that, you're going to ask questions, you're going to do that check, both observing and listening. And then you're going to do that bridging. And that bridging is to designated individuals, and it's going to be up to them then to use their skills to make the determination to go from there. For example, from a behavioral health point of view, if it is a panic attack, I'm going to go into some specific, as a psychologist, I'm going to go into some specific directed relaxation techniques, which would use directed self-calming breathing and self-talk techniques to bring down that physiological sympathetic nervous system hyperarousal of the panic attack. And that would be, what core action would that be? Well, obviously that would be core action calm. And next week, I'm going to be demonstrating through a video, an example of how you do that with somebody who is has a problem with panic attacks in a crisis site, disaster site situation. Good example. Teresa, you're muted.
I do that at least once a meeting. And if I could echo that too, I have been at a lot of vaccine pods and have had this happen frequently. So it's not uncommon. And fortunately, whether they're having a panic attack or an actual start of an anaphylactic reaction, it sort of presents the same way. So I would definitely echo what Dr. Call was saying, that if you are a medical person, you're gonna start doing your assessment either way. And if you're not a medical person, just try to stay with them. And like Dr. Call was saying, we use a lot of breathing techniques, some distraction as well. So tell us about what you're doing today, because we have a lot of people that are just nervous about getting their vaccination. So we do a lot of, I'll stand on the opposite side of the side where they're actually about to get their vaccination. So tell me about your day and what do you do for a living and what's going on, and what are you going to do this afternoon or this evening or this weekend, or some of the same basic kind of distraction type techniques we use with kids when they're getting their immunizations as well. But so if you're not a medical person, stay with them and alert one of the medical people, and you can start to employ these techniques, which are going to help whether they're having a panic attack or a medical emergency, because each one, we want to try to calm them down as much as possible, like Dr. Call was saying. But then also you can have the medical people there to start doing further assessment and getting some medications ready if needed. But we've actually had this happen quite a bit. And I'd say 9 times out of 10, it's more a panic attack than it is an actual medical scenario. And those techniques are absolutely critical to start, and just to talk with the patient, and eventually they calm down, and then they're very grateful that you spent the time to stay with them and help them through it. And so, yeah, it's a very great question and a very relevant situation that's actually happened quite a bit, or at least in my experience. Okay, had a question from Sarah. She says she's a behavioral health aide embedded at a public school. Do the procedures and methods change at all when dealing with children versus adults? Great question.
It depends. Depends on the age of the child. With teenagers, it's pretty similar. Younger you get, the more different it becomes. Almost, what's this questioner's first name, Teresa?
Sarah.
Sarah. And Sarah says she's a behavioral health professional at what kind of a school?
Public school.
Public? Is that Sarah? Sarah, if you have experience with elementary and children, I would defer to you because frankly, I am a adult-oriented psychologist, particularly, unfortunately, criminals. But my experience professionally with preschoolers and small elementary age children is about that big. And I would certainly, defer to people who work with them. You got a good murderer. I can handle murderers, but
Well, I'm in middle school, so that's kind of, that's pretty bad.
But with teenagers, I usually interact with them fairly similar to adults.
And I would, just if I could pop in again too, I would say that we, at least as medical professionals, we tend to not address our audience very well at times. And we tend to use the foreign language of medical terminology a lot when we're talking to really patients of any age. And I think it's important for us to, just like if we were going up on stage to present a TED Talk, we have to consider our audience. And so if you're talking to children versus adults versus criminals versus whomever, it's really, I think, important to make sure that the language you're using is appropriate for the audience you're presenting it to. So with kids, I would say make sure to use, and I don't want to say dumb things down, but you want to put it in terms that they can understand. And the same is true for adults as well. So like the example that I was given just a second ago, when I'm using distraction techniques with a child who's getting an immunization, I'm going to ask them about their favorite toys and what do they do in school. If it's for an adult that is very nervous, I'm going to ask them, where do you work and what do you do and where are you going to go first when this pandemic is finished, and who are you going to visit and what fun thing, So I think it's important for all of us to really make sure that when we're communicating with the public, whatever age, whatever race, whatever ethnicity, is that we make it in terms that they understand. I think that's something that as medical professionals, we don't do a great job doing, and we need to do better. Janet made a comment, I've worked with children so long, I have a hard time communicating with adults and adults. Absolutely. So I have a question, Dr. Call. What sort of examples have you seen recently at our pods? I know some of the things that I'm starting to see with some of ours are basically provider burnout. I think a few of our guests also mentioned that as well. But what kinds of things have you seen with the pods that we've been having?
Well, first off, let me just state that because of my age and health issues, I've not volunteered yet at a pod. I need to get my inoculations first, and hopefully, and thereafter, I will be volunteering. However, I have went to a pod and as a citizen and got my first inoculation. And what I found utilizing myself, I've been in the Air Force. I've spent a lot of time. I've gone through pod exercises. I remember my first pod exercise was like in 2007 or 2006. And I went to the pod at Logan County, Guthrie, and I found myself being anxious. I would diagnose myself as moderately anxious in the yellow zone and moderately confused. Because I mean, it's like I go here to this station, I check in to that station. Now I understand the stations afterwards, but before it's kind of like, where do I go next? Well, we went over to this other station to fill out paperwork. Then we went to a third station to give the paperwork. And then we went to a fourth station to get the vaccination card. And then we went to a fifth station to stand in line. Then we went to the sixth station to be inoculated. And then we went to a seventh station to wait. And this, of course, this was all, I know post hoc that there were all these stations, but at the time it's like, whoa, this is kind of like overwhelming. So from the citizens' point of view, I got a real taste of it. And what it is it's a bit anxiety. It's moderately anxiety provoking, and it's moderately confusing. But it's not the fault of the structure of the pod or the people. The people were friendly, etc. It's just the circumstance. That's one of the things I think that I'm really glad that people are attending this program, and I'm designing a 1 hour super narrow presentation that all pod workers can view, because I think that specifically utilizing SFA techniques to help that citizen through that pod is going to be one of the major things that a pod worker can do and use SFA. I also think that using SFA to deal with your own tension and stress, as well as to help your peer in the pod worker deal with this, particularly as you say, Teresa, I think there's going to be a burnout issue. Traditionally in a disaster, we have this rubber band effect. People come in, rush in, and they stretch that rubber band to try to meet the need. But we can't do that for 12 months. We'll break. We're going to have to see this as a marathon, not as a sprint. And so I think that really emphasizing and learning these tools, practicing these tools with ourselves, with our family, with everyone around us, is going to be extremely important.
This is Janet. I've worked several pods now, and I've used a lot of what we've learned in class from you, Dr. Call, especially in the SPF class or whatever.
Yeah, skills for psychological recovery.
Yeah, I've used that a lot. I did a bunch of the pods where they were doing the emergency workers and responders and stuff. And I would go in and ask them, so what's your biggest stressor through all of this? And then boom, boom, boom. And those people were so appreciative to have somebody to talk to about that. And I noticed that it seemed to help just to have somebody to ask them, how are you feeling? Instead of, here, let me stab you and move on. And so, yeah, and then I haven't done any of the younger age group pods yet, but I've done older ones. And those people were just so grateful to get the shots, and they couldn't believe how calm everybody was, because what they'd seen on TV, they came in so anxious and expecting, all this chaos, and it was so calm and easygoing that they appreciated it. So, I've had really good experiences, and the people I've worked with have been rock stars. Those healthcare, people and going in there and trying to get hundreds of shots a day. And we've done it in garages. We've done it in crazy places where it was so cold you could hardly move. And they're still there the whole day. So it has been amazing opportunity.
Now, this is Dennis. I just like to add on to that. The first part I worked was actually in Guthrie in late December with first responders. So maybe that was when Dr. Call came through later. But a lot of firemen and EMTs were kind of joking with each other and carrying on and, helping lower their own stress. But one of our volunteers there, she was kind of offended that they were having such a good time sitting in a pod, getting vaccinated. And I just tried to calm her down because she thought it was kind of disrespectful for them to be kidding around. But man, that's what was relieving their stress. And I think it's important that we recognize that because we're going to have so many new volunteers coming into these pods. They show up that first day. I think it's important for those of us that have been involved with the pods that we have some opportunity to bond with the newbies that are coming in. I know everything gets so rushed, but I'm just thinking even like a debriefing at the end of the day with all of the new volunteers, that the unit leaders would take a little time to just kind of help see what their reaction was to that first day of being in such a big pod like the fairgrounds here, where we may be doing in Tulsa 1,700 individuals a day, huge number of volunteers, great effort. But I do worry about making sure that we're supporting all those new people coming in, that they recognize it's in for the long haul, but we're all in this together and get their feedback on their first experiences.
Very well said. And another thing, I would like to invite everybody who is attending today. I have been contemplating designing and implementing a monthly or bi-monthly webinar, very, very short webinar, like 1 hour, that would be informational in nature for pod workers, both volunteers and staff, that would answer or provide information on issues. So therefore, what I'm asking is like what Dennis just stated. Dennis identified a issue. I would like anybody to feel, everybody here, to if you identify a issue or a concern, or you have a thought that might be met with a small informational webinar, email me and Teresa, because we're collecting, at present, we want to collect topics that would be of interest and worthwhile to present throughout the year in a short webinar concept. So thank you, Dennis.
Okay. Does anyone else have any last questions or comments? Yes. So Uria, I think I said your name right. She did a pod and everyone was anxious and smiling and chatting. Congratulations.
Yes. Yeah, that was me. Actually, I'm just at a Starbucks right now, but yeah, so I just went through one pod. I'm sorry. So, but it was just my first pod, and there was a lot of elderly people coming in. Getting an appointment was a lot of stress for them. And honestly, people volunteering and working there were great, but I was a volunteer for the first time. I guess I was really excited myself, but just smiling and even just saying like, hey, congrats. And I just saw this sudden relief because they're like fumbling with their paperwork. Like, is this right? Is this what you need? You know how nervous they are just walking in, making sure their appointment is right and they'll get the shot and all that. So just some friendly hello chat, just basic, stuff that really provides relief too, I feel.
Yes, thank you for that comment. I can say too that just when the person comes to your station, whether you're doing registration or actually vaccinating or monitoring afterwards, whatever that role is, just to, like you said, just smile and say, hi, how are you doing? What's the rest of your day look like? Are you feeling okay? Just any personal contact at all really helps relieve that stress, because there are a lot of people that are very stressed out about what is this vaccine going to mean for me 10 years down the road, but we don't have. I've had a lot of discussions with people about what does it mean if I get flu-like symptoms afterwards, and that is a normal part of the process, and trying to, again, put it in terms that they would understand that that's actually what we want. That means the body is, identifying that foreign substance so that it can fight it anyway. Just having those conversations and trying to put people at ease.
Yeah. And I would tell you that, just even myself going in for my appointment, the first appointment, there's a lot of nervousness about just getting in, right? I mean, that's the biggest thing. So once they do make it, especially people who are coming in for the first appointment, at least like back a month, it was like a month back. There was a lot of confusion about the second appointment, and there were some agitated people, some angry people. It was so hard to come in, and why are we not getting an appointment for the second shot right now? That was a fairly common question. And I'm so glad I was a volunteer, because it was slightly harder for the county health worker to answer that. But as a volunteer, as somebody who went through the same process as all of those people coming in, I was able to kind of relate to them and kind of help them kind of share my process. What I did, and how this can be done for them too. And again, just empathizing with them and validating their feelings and emotions. So just those basic counseling skills, I guess.
Yes, absolutely. Good point. Good point. And then Sarah said, I think laughter can be a useful coping strategy and stress reliever. Absolutely. Yeah. All right. Does anyone else have any questions or comments? All right, perfect. So I just wanted to remind everyone that the next offerings, so part 2 and part 3, are going to be next Friday and the Friday after that. So it's 3 Fridays in a row from 10 to 12. Please do register on the OKMRC website for all 3 offerings. And then if you have questions about CE for nurses, please contact me directly and I'll send you the information. For everyone else, if you go to the website and use the code that we put in the very beginning of the slide deck, and it is in the registration from the MRC webpage as well. Can get CEs that way. And we will, like I said, we're working on a way to be able to share the recording and the PowerPoint with you all. So there will be more information on that. And Dr. Call, did you have any last comments? I think he may have had to step away. Okay, well, thank you all for attending. Thank you so much. We have enjoyed having you here. It's been nice to do some training, although we haven't been able to get together in person. It's been nice to finally figure out how to do some training over Zoom. And hopefully we'll eventually get back to doing this in person. But thank you all for attending. Thank you for your time. Please contact me if you have any questions. And we will see you all next Friday. Thank you so much.